research centers are located. Sorry, I'm getting a message about recording, where research centers are located, and there's also supportive infrastructure that is robust. So there's more opportunities for public transportation, for clinical venues, for recruitment, and so a lot of our work around substance use and infectious diseases is really being driven by these urban centers, which can't be translated or transferred to more rural communities because of the various demographic and sociocultural and infrastructural differences. So some of the primary barriers that create some of these roadblocks can include perceived stigma, just as my colleagues previously talked about within their specific study populations, but also scheduling difficulties, transportation difficulties, community level distrust of the research process, and then also limited investigator cultural competence working from non-urban communities. So definitely addressing some of our own limitations in terms of investigators that are driving this work. So this has really been an effort in terms of developing some deep-rooted community-based engagement within some of this research. So Appalachia Unite is our logo that encompasses all of our varying funded projects and interventions in Southern Ohio. The phrase and the logo itself also represents our collaborations as the development process included input from many community members and organizations. So we have 3 projects. We have OHOP, which is our parent project. It's the Ohio Opioid Project. And this is a community-based study that informs a service delivery plan that can reduce barriers to key drug-related services in order to improve opioid-related outcomes, including overdose and infectious diseases, et cetera. We also have Proud R Squared, or Proud 2, or Prouder. We kind of mix the names up a little bit. But this is actually a randomized controlled trial that is funded by NCATS that tests strategies to improve the retention of people who use drugs in research within rural communities specifically. So it fosters facilitation of rural participants into these clinical trials. And so we have some preliminary data that we'll be showing you today with this out of this particular study. And then also Ignite Ohio, which is a smaller sub-study with an emphasis on focusing on an even more hidden population within this hidden population of women who inject drugs, given that they have a unique set of risk that they may experience in comparison to some of their male counterparts for the transmission of hepatitis C. So these projects are a collaboration between Ohio State University and University of North Carolina, which was my previous institute, and where we still have lots of collaborative efforts occurring. And these studies are also funded through NIDA, the National Institute of Drug Abuse, and as I mentioned, the RCT looking at retention is funded through the National Center for Advancing Translational Science. So our project setting takes place in rural Appalachia, Ohio. So we are working primarily in Scioto, Pike, Jackson, Gallia, Meigs, and Benton counties. And the rationale for this is if you see that image to the right there, this is the death rates per opioid overdose by county. And so you can see that we're really primarily focusing in Southern Ohio below that line for the Appalachian counties that are hardest hit within the opioid epidemic. And we have several project collaborators that we have been developing and fostering partnerships with for not only the implementation of these projects, but also the design. It was the Ohio State Extension Office, as well as working closely with other community partners who recognize the need to address the growing hepatitis C epidemic and opioid epidemic in Southern Ohio. So the designs of these studies really came out of that need that was identified. And so our partners include the various county health departments, Equitas, Holser, Adamich, board partners, OSU Extension, as I mentioned, Ohio Department of Health, the police department, et cetera. And so through all of our various partnerships, before we've even begun the implementation of actually engaging and working with people who use drugs within the community, we developed a community leadership board, which includes 11 stakeholders that are representatives from each of the counties that we're working in. And this board is critical to the development and the implementation of our studies, but also specifically for some of our service delivery plans as part of OHOP. And so through our meetings together, the board developed their own unique vision and mission statement that I think just truly demonstrates their commitment to their work. And I just want to highlight here that vision statement. So as fewer residents start using substances and more are in recovery, Jackson, Pike, and Scioto counties specifically will break that intergenerational cycle of addiction, which I think is quite a powerful vision that we're happy to be able to help foster and come to fruition. So as I mentioned, this is the culmination of 3 projects. So we have lots of varying research methodology, and I'll highlight just one of our recruitment strategies because I think it really speaks to more of the design aspect and some of the ethical and regulatory challenges. And then Cathy and Renee will also talk about some of the actual practical implementation tools that they've been using. And so we use a combination of legal mapping, policy surveillance, qualitative in-depth interviews, behavioral survey administration. We also do hepatitis C, HIV, STI testing, and drug testing as well. And so our recruitment strategies really involve being engaged within the community as much as possible. So that could be tabling within community events across the counties that we're working in, and Cathy and Renee can speak more to that. We're working closely with our community collaborations in terms of attending county health and drug coalitions and health department meetings, or even services that are being provided, say for example, the Portsmouth Syringe Service Program. And then also respondent-driven sampling, which is our primary recruitment method in terms of actually engaging people who use drugs. So respondent-driven sampling addresses some of these issues related to stigma, mobility, and the legality, as well as the absence of adequate sampling frames for high-risk populations. And so all of these create these challenging environments to be working with, and RDS helps address some of those challenges. So RDS, you have these seeds who are these initial participants that meet your eligibility criteria, who are identified within the community, and then you provide them with coupons to then recruit or refer, if you will, people within their peer groups. And so those new recruits then also come in and they present a coupon, and then they enroll in the study, and then in turn they're also provided with coupons to where they then continue and go back to their social groups or their peer groups to recruit new individuals as well, until that sample, that desired sample size is reached. And so as those seeds break out and recruit people, and then the people who are recruited then recruit others, you're creating these chains that you can see there on the left. So for scientific and practical reasons, RDS is an evidence-based approach for reaching these quote-unquote hidden populations that are routinely underserved. However, this is not without ethical and regulatory challenges that have to be considered and also addressed when obtaining some of the ethical approvals. So first, I just want to emphasize that RDS is not coercive. It does not cause undue inducement and does not compromise the voluntariness of the nature or of the nature of our research process. And this is because participants recruit from their social networks. So rather than necessarily being recruited over and over again within the community by members of our research staff or a research team, they're actually recruited from members in their peer group. And so it minimizes the potential for disclosure or perhaps some undue harm within the community. And the consent is truly within that spirit of the voluntariness of the research participation. So participants who come in are offered the opportunity to recruit some of their peers, but then they're not required to. That's not required in terms of their obligation to participate within the study. They're still able to participate in the study regardless of if they're recruiting anybody. So again, there's that voluntariness in terms of if they feel comfortable identifying or approaching peers about their participation. So RDS does provide a token incentive for their peers enrollment. So participants who are provided coupons. If they have a peer who comes in with their coupon that is matched and can be traced back to them, then they do have that opportunity to be incentivized or receive a financial value to compensate for some of their time. And this tends to be relatively small, and in order to ensure that we're avoiding any type of quasi-professional recruitment, and the number of coupons that they're actually provided is quite small, usually around 3 to 4. So in terms of our projects, we've had several milestones over the past 3 years that we've been actively working within the community. And so we've completed nearly 300 interviews with PWID or PWUD via RDS. We've also completed about 70 PWID interviews with participants who recruited specifically from the Portsmouth Syringe Service Program. We've conducted 30 PWID qualitative interviews, and then also stakeholder interviews as well. That includes healthcare providers, substance use treatment providers, law enforcement, judiciary, and other related organizations. And then, as I mentioned, and highlighting that vision and mission statement, we've formed a community advisory board, and we've had 5 monthly meetings that have been held and continue to be held, although we're now looking to explore other options for how to continue that. I took out some of our key themes from our stakeholder interviews just to provide a little bit of a contextual environment that we're working in. So these interviews came from our stakeholders who participated in OHOP, and they talk about the community stigma surrounding addiction and also treatment and harm reduction as well. They talk about the sustained economic depression and community trauma, which creates also this environment of distress, not only with, the participants or people within the community who use drugs that were trying to engage in treatment or other related harm reduction. But it really just creates this environment that's challenging to work in. There's also fragmented interorganizational collaboration, which again makes it more difficult in terms of bringing members from different community organizations to become part of our stakeholders within these studies, but then also to participate on our community advisory boards. We're trying to identify ways to enhance collaboration for all of those organizations as well. We also have the key themes related to PWID or PWUD, and they've included those who have access services and those who had not as well. But there's one key theme that I wanted to highlight here, which is the tension with healthcare professionals, because I feel like this tension really translates to perhaps the tension with even clinical or research community in terms of that perceived or experienced stigma. And so we have to be careful to overcome this. And this quote specifically is, it was hit and miss. Sometimes they were, professional, nice to me, you know what I mean? And I remember one doctor in particular, I could even tell by how he was looking at me. He thought I was full of shit, He was looking at me in a very condemning and judgmental manner, speaking to me in the same way. So it was just hit or miss. And these are lived experiences from our participants. And so one of the biggest challenges that we have is to create that trust in order to make sure that our staff is not only trained in non-judgmental mannerisms and study implementation, but are also living that in terms of all of their engagement with participants. So we actually had the chance through our NCATS funded study to conduct a descriptive cross-sectional survey using responses from participants who were recruited from Portsmouth's Syringe Service Program. And we identified the motivations as well as the preferences and barriers to participating specifically within clinical trials. So this is very specific to clinical trials rather than an observational or behavioral study. And so in terms of the primary motivations to participate in research, it included believing in the mission of the research study, wanting an opportunity to share their story or trying a new treatment that's been offered, but also to be able to encourage some of their friends and family or partners that participate. And I will put in here as well that financial compensation for time and transport. It's very challenging for participants to be able to identify a mode of transportation in terms of coming to research or clinical visits as part of our projects. And so the financial compensation for time could be a huge motivation and also a potential barrier to address. In terms of the preferences, the more ranked or the preferred ranked attributes in terms of preference participating in clinical trials included appointment length, again, some type of financial compensation, but also confidentiality, as well as that time that they're spending within the office. And so in terms of the reported barriers, that financial compensation, I think, really speaks to this in terms of the trouble getting transportation for their appointments, not being able to get in contact because they recognize that their contact information changes, as well as their peers' contact information is changing pretty regularly. And then also challenges in terms of showing up for a specific appointment time, which again kind of translates back to some of the lack of the transportation infrastructure within the areas that we're working in. So in terms of some of our lessons learned, we've identified, the stigma toward PWUD or PWID or users or harm reduction services are quite prolific throughout the community and at varying levels in terms of healthcare, but also perhaps treatment providers or community-based organizations as well. We need to leverage the research mission and be clear about what the research entails and explicitly address participant confidentiality and privacy to perhaps improve participation within these settings. And then also transportation, losing contact with participants, and stringent appointment times could be the greatest perceived barriers in terms of retention. So not only recruiting and enrolling these participants, but also retaining them over time. And then the challenges in the field, which I'll let Cathy and Renee speak to much more in depth, but PWUD recruitment, momentum is slow, and it's particularly slow in areas with a limited harm reduction infrastructure because there's lack of a centralized area where people feel that they are able to trust members of the community in terms of engaging in services that are already there. So when we do not have that harm reduction infrastructure, you see that the social networks are much more dispersed throughout the rural areas. So I did put this in just as some thought. So we're definitely in the initial stages of trying to consider how we're going to continue our research amid the spread of COVID, as well as the social distancing measures that have put in place. And so we're exploring these opportunities to ensure the continuity of our research and services. And so I want to say that these were by no means evidence-based, but just some of the considerations that we've been talking about within our team. And a lot of this has been informed by seeing the creativity of the businesses across Ohio in terms of how they're planning to address the social distancing measures that are put in place. So these have not been evaluated for any type of feasibility or acceptability, but just some of our initial steps and what we're considering. So conducting qualitative interviews by Zoom, FaceTime, or by phone, pursuing written consent through DocuSign or RedCap, the ability of leveraging the postal system or emailing gift cards, but also identifying ways to obtain reloadable gift cards for participants. We're also exploring the options in terms of limiting the number of participants within our research building. And lastly, conducting interviewer-assisted surveys either by phone or perhaps in separate cars with windows open, somewhat mimicking that curbside pickup that we're seeing with some of the businesses across our state. So given the complexity of these projects and the considerable community engagement, our team is quite large and everyone plays such a critical role in these efforts. And so I just want to acknowledge them, including Renee and Cathy, who will be talking next, and then also our funding sources for these 3 projects. So Pam, I don't know if it makes sense if we should continue on or take questions.
Yes.
Okay.
No, I think let's just go ahead and then we'll see where we are with time. So.
Okay.
So Renee, you have this.
You should be able to share your screen, I think. Yes.
Yes, just a second here. Yes, can you hear me okay?
Yes.
Okay. So I'll be talking, I'm Renee McDowell. I work with Cathy, Neal. She can answer questions at the end too, but it was just kind of easier if one of us went through this, and I'll try to move quickly because I know we need time for questions. But we are looking at recruiting people who use drugs in Appalachia to research studies. And as we talk about this, as Cathy mentioned already, a lot of what we do is work with organizations. We did a lot of going out into the community to meet people and then see if they would hand out our information to people they work with. So places like Community Action, WIC, Jobs and Family Services, and drug treatment centers, to try to just meet those people, gain their trust, and then that way they could pass on that information to the people they see every day. Also, we attend drug coalition meetings and try to get involved in events with those groups. So some of those are maybe events for kids we've been to where they'll have them do collaring pages to hang up around town and have marching things. It's all prevention with kids against drug use. We've attended those. We've attended provider fairs. So other, just again, trying to find anyone that can help us recruit folks. And then networking, just going into all kinds of businesses, talking to people, introducing ourselves, leaving information at any business that would let us on how to get a hold of us to participate in our research. So I have here direct recruitment by placing flyers, libraries, stores, anywhere that would let us hang up a flyer. We did a lot of tabling in front of grocery stores, food pantries, any place again that would let us, pretty much trying to reach people that way. We attended fairs, like I said, drug coalition events. And really the way that we did best though was at needle exchanges, specifically at Scioto County and the health department. We were also in Jackson and Pike. They didn't have needle exchanges there in those counties, so we couldn't do that, and it was harder definitely to recruit the first people. Cathy talked about the respondent-driven sampling. So again, when we get those first people in that found out about us, however they found out about us through, someone at a business or drug treatment center or whatever, or if they saw a flyer and called in and they were eligible to participate, our goal was to really, be as kind to them as we could, treat them as good as we could. We always had coffee and snacks and they enjoyed that kind of thing. But just explaining to them everything about, why we're doing the study, how we want to help people in the future, and hopefully this information could be used for those interventions to help people in their counties. So a lot of the work was just once we got those first people in to get them to trust us that, everything was okay, nothing was harmed, nothing came bad to them from the study. So of those, you see we did 261 interviews, 46 were seeds, and the rest of the 215 were referrals. So that shows you that it worked pretty well just to get those first people to reach out to the people that they already know. Challenges of recruiting in Appalachia, just the large area. We've been in 3 counties. We're going to be in 3 more counties. A lot of traveling, difficult for people to get there and keep appointment times. That's just Appalachia in general. Finding available office space was a challenge for us. We try to have one office in one of the 3 counties we're in at the time, and then borrow space in the other counties just because it's so expensive to rent offices in every county we're in. And sometimes that was difficult, just, you know, convincing the people that share the space that, you know, we're going to be cognizant of their time and try to keep participants from doing anything they shouldn't in their building and that kind of thing. Establishing trust, especially people from out of the area, and reassuring that everything is confidential. So again, I'm from Appalachia. This is just kind of the way it is. They kind of trust people. So I know a lot of our staff are from the Appalachia area, and that seems to help. If you can say, oh, I'm from the county next door, they kind of seem to be a little more at ease with you. Lack of knowledge of research and disbelief that their participation will help. So just getting them aware of what's going on and how we are going to help in the future. And then as I was looking at this, you know, originally it said challenges of recruiting people in Appalachia, but I thought there was a lot of difference between just folks in Appalachia, because I've worked with that before, and then challenge of actually recruiting people who use drugs can be different. So the challenges we ran into with the people who actually use drugs is more trust issues, because not only do they just not sure whether to trust somebody from Ohio State coming in and doing a research study, but then they're also concerned, will we turn them in for their drug use or selling drugs? Or a lot of these people will at some point admit prostitution to support their drug use, theft. And so, you know, they want to make sure they're not going to be reported for those things. One health department we had was next to a police station, and sometimes when people would call in, that could be a worry of theirs. You know, if they were seen coming in, would the police know why they were there, and that kind of thing. So we had to reassure them that that wasn't the case. Physical issues with folks who use drugs. You know, we've had people come in that you could tell were still high, and you have people come in that are drug sick. So you have to work around that. A lot of agitation at times, sleepiness. If they had an inability to understand, we did a comprehension test to make sure they could say back to us what they were going to do that day. A lot of times they were in a hurry to get done. Like the beginning, they would be fine, but as they were getting closer to needing a fix, they were in a hurry to get out of there. So just trying to keep them around and calm them down. Lack of permanent housing, transportation, that makes it more difficult to keep appointment times. A lot of the people in Scioto County I know lived in a homeless shelter, or they were going couch to couch. So trying to, you know, get a hold of those people, their cell phone numbers change frequently. It can just be a challenge. And then stigma. So again, a lot of the people are used to, like Kathy was saying, not being treated very well when they go into offices and things. So just trying to treat them as good as we could. And a lot of people would say, oh, you know, you treated us like we were actual humans. So making sure that you do treat them well and give them respect as they deserve. So lessons learned, again, gaining trust. I would say that's the biggest thing in Appalachia, and especially with this population. You have to get the trust of the people in the community as well, so they will send people your way. Again, if you can hire research staff from the area, that seems to help. Show them that you value their time, and they do get gift cards. That definitely helps. And then let them know, some of the data we got back was that from qualitative interviews that they really did like helping others. So if you can let them know that that's part of it, you know, that the information is valuable. We found the peer recruitment worked well. We didn't get a lot of response from tabling and hanging flyers, but I will say I know there were some of the seeds that we just happened to get, like maybe one person from a tabling event, and then they did send us more people. So it's kind of where you got to start. Now I talked about reimbursement, and then also we did the HIV, Hep C, and syphilis testing, and they did seem to like getting those test results back. Some of them, a lot of them knew or suspected they had hepatitis, but you know, hopefully some of them I know linked to care and help them out in that way. So that is all I have.
So great. We really are down to 7 minutes or 6 minutes. I just have to make one observation across the two presentations in terms of challenges for hidden populations. There were a lot of similarities between the groups that were discussed. And so, and that wasn't planned, but it's interesting that the importance of engagement and development of trust with these populations is fundamental to the work. So I'm going to just, is there one or two questions that we might ask Stuart, and then I'll let you wrap it up because I want to stay true to our time frame.
Yes, there are a couple of questions you might see about how you did IRB applications for longitudinal projects.
Yeah, so that I did see that question. Thanks, Stuart. So I will say for the longitudinal project that is currently funded by NCATS, that's a multi-site RCT, and we also work collaboratively with University of Kentucky and Oregon Health and Sciences University. And so given that it was an NCATS multi-site funded project, we were really encouraged by NCATS to submit a single IRB and with their preferred IRB, which was out of the University of Utah. And then we applied for OSU to have a reliance agreement on that submission. And so I'm happy if it would be useful to talk through some of the language that we had in terms of the challenges that we had, even just with some of our cross-sectional surveys that leveraged the RDS. There was quite a bit of back and forth with OSU's IRB in terms of providing some of the evidence around respondent-driven sampling, around the evidence specifically relating to the minimal opportunity for coercion, as well as continuously monitoring social harms, even though it's a cross-sectional study. We're trying to do that, and we've implemented that within our protocol for OSU's IRB. But I agree. I see that writing those sections can be quite challenging. So it's a little trial and error, but we're happy to help any way we can.
Did you all make use of the CCTS's recruitment and retention services when you were doing any of this work?
We have not, and that is something to explore.
And just remind everyone that that is an important resource, the CCTS.
So Stuart, do you want to just go ahead and wrap it up? Just a sort of overall apologies. You noticed when we started recording, so we'll sort of figure out some ways in which we can maybe make slides available and resources available to the group. And Jeff and Stuart and I will chat about that when we're done. So Stuart, it's all yours.
Well, I've just mentioned, first of all, that you'll be receiving an evaluation as early as tomorrow morning, just to ask you to get some feedback about this program. And I've also put up on the screen there that the CCTS is having a program on managing research integrity during the COVID-19 emergency. And we'll have some, it's kind of taking off from the Office of Research, which issued a statement about managing your research integrity during this time. And so just kind of some various researchers talking about things you should be thinking about always, about data management and authorship and collaboration. And also how maybe to make sure everyone on the team is conducting ethical research. And so there's information there on our calendar for on May 14th. You can go to the CCS website and look on our calendar. You'll find the link to register for that. We also did have a final poll here about if you're interested in kind of lifespan research that you might be interested in, and you could make a response to that as well. And thank all of you for attending, and hope that you gained some important and useful insights from this. And since you registered, we have your contact information. We'll be able to reach out to you and make resources available to you.
And I want to add my thanks to the presenters. Great job. I think we set the high bar for our next one, but thanks for all that you did to make this a success. And I just call out Stuart in keeping us on track. So thanks again, Stuart.
Thank you. You're welcome. Thank you guys for putting this on.
So stay safe, and we'll hopefully have another in this series announced here in the next 6 weeks or so. Thank you all.
Great, thank you.
Thank you for having us.